I am Professor Bashar, Harunai Foundation, Dhaka. I want to talk anti VEGF in diabetic macular edema. It is an important topic as because that is DME is increasing throughout the world as the physical activity of diabetic patient or due to the facilitation of internet and other device. In diabetes, there is a poor scenario for impairment of vision. One is that is early onset, that is diabetic macular edema. Late onset, diabetic may lead to proliferative diabetic retinopathy, tractional retinal detachment (TRD), vitreous hemorrhage, macular ischemia, and vitreomacular phase changes. In DME, the occurs due to in uncontrolled diabetes. There is an increased accumulation of sorbitol and aldose reductase protein kinase pools and galactose, and these things and at side by side there is a release of vascular endothelial growth factor which causes subclinical inflammation and leukostasis. These leukostasis may cause loss of endothelial cell and pericytes of capillaries in the peripheral area and other area. As the sensitivity of vascular endothelial growth factor is varies in individual. Some individual peripheral capillary is very sensitive to endothelial growth factor area of the peripheral retina. Those who has the peripheral capillary of high affinity towards the vascular endothelial growth factor, they cause this type of changes and cause leakage, and this leakage the fluid in the macular tissue. That is initially normal case, there is no fluid, minimum or selective fluid is coming into the tissue by tight junction of the endothelium. But when tight junction is loose, there is plasma is leakage through the capillary from the capillary. Why neurosensory detachment in diabetic macular edema? There is plasma leakage in the retinal tissue from the capillary causes the fluid in the extracellular space and which is absorbed by cells. Some fluid is present in the extra. That is, if the plasma is long standing, then the lipid portion is not absorbed, so it is deposited in the retina in the form of hard exudate. When this fluid goes towards the subretinal space for drain out, but they face a tight junction of the retinal pigment, so it cannot be drained. When the excessive amount of fluid in the subretinal space, and then it pushes the neurosensory retina towards the vitreous interface and causes this cessation. Here you can see that is the neurosensory retina is detached by means of fluid. And diabetic macular edema is early DME and long-standing DME. And aim of treatment of DME is to dry the macula, improve the vision, and maintain dryness. And if we maintain the dryness for a longer period, we can provide patient a stable vision. Home to treat, the criteria of treatment of DME, there is DME, when DME is central, no traction, no retinal membrane, no PTR, and whose vision is 20 by 32 to 20 by 320, and lateral score is equal to 78 or less. And central subfoveal thickness and central foveal thickness is 250 micron. Even vision is 20/20, and this, if the patient have this criteria, then this patient to be treated. And treatment option is anti VEGF, there is an intravitreal steroid and laser. The function of anti VEGF, this is the first line of treatment of diabetic macular edema DME. As it has got anti-inflammatory action, enhance the tight junction of the capillary to prevent leakage, increase the absorption of fluid, and enhance the stability of superficial and deep capillary by repair of capillary tight junction. And different type of anti-VEGF that it is proved scientifically and studied, that is highly that is FDA approved, and this is the dose. And the recent is ranibizumab is the next group, and the bevacizumab Avastin, it is widely used throughout the world. It is like it is a third world country like ours, but it is off-label use. It is not FDA approved. This is there is a bevacizumab vial, and this is the Lucentis, that is ranibizumab vial. And this study, that in the study it was found that the that is aflibercept has got better than regarding vision, better than other two. This is the aflibercept, this one is the ranibizumab, and this is the Avastin. After 2 years study. Which anti-VEGF? That is aflibercept. Idea is the best, costly, but next is the ranibizumab Lucentis. And these are the protocol of giving the intravitreal Lucentis or ranibizumab before the topical antibiotics, before and after. Then topical anesthesia, povidone iron to be installed. And after wash the bed, and I prefer to intravitreal injection in the OT, as because though the endophthalmitis, to avoid endophthalmitis, though it is rare, but I have to adopt a highest precaution. Allowing time for povidone iron to dry, and sterile caliper to locate the injection site, and draw the ranibizumab in a sterile syringe by means of 19 gauge needle. Then it is replaced by 30 gauge needle, and the drug is injected to the vitreous cavity with the needle pointing toward the optic nerve. And after washing and draping the eye, povidone iron was given, and then mark 4 millimeter away from the limits as it is Faki guide. Then the needle is pushed, that is to make a tunnel in the sclera to prevent leakage. Then it is pushed towards the optic nerve, and after giving the injection within the vitreous, cotton bud soaked with povidone iron is placed and pressed so that the injection cannot leak. And it is found that there is no leak, as there is a tunnel into there is no leakage of. Assessment after giving injection, that is if the vision is become 20/20 or 10 or more letters, and central subfoveal thickness is less than or equal to 250 micron, and improving on visual acuity, that is 20/20 less than 20/20, but improving 5 letters or more, and central subfoveal thickness decreasing more than or 10%. Not improved vision, that is decrease 20/20 or less than 5 letters improvement, and central subfoveal thickness is more than 250 micron, is less than 10%. And this is the presentation, the symptom, this non-clinical examination, that is if a patient present with this that is without symptom, but OCT shows a small cyst and the central subfoveal thickness is less than 250 micron, then it is recommended to follow up. And after follow up every 1 or 2 months, when it developed, that is there is increment of the cyst and increased thickness of the retina, that is especially subfoveal and central subfoveal thickness and central foveal thickness, decreased visual acuity, then there is anti-VEGF to be given 4 weeks interval and 4 weeks of follow-up. And this is the final, that is a DRCR net, that is I concise this why we that is treat the DME central, no traction, no epiretinal membrane, no PDR. With treat in the another option, another protocol, and this is that is protocol. Different protocol is that, but for DME I prefer the T protocol. According to T protocol, follow up that is up to 52 weeks But another part they mentioned is 2 years follow-up. I prefer to follow up 2 years, because if we treat this patient with 2 years and keep the macula dry for 2 years, I think the patient may cure permanently, or the patient that is safe from the life-threatening situation. And if situation that is arise with this, we can extend this follow-up in 16 weeks, another 16 weeks. But the diabetic patient is the patient like hypertension and on other systemic disease like bronchial asthma, and he needs throughout need there is follow-up throughout life. But if we treat this patient initially, we have to follow up this protocol. In this protocol, there is anti VEGF injection to be given. That is in this way. There is continuous 4 weeks interval 6 injection without delay and without interruption. 6 injection 4 weeks interval, and 4 weeks interval follow-up along with OCT for 2 years. That is in first year. That is if after giving 6 injection, if the macula is not dry but improving, in this situation another 4 injection to be given in the first year, and in the second year that is accruing another 6 injection to be given in that is 4 weeks interval when and arise. But the macula remain always dry till the removal of the cystic space. After first injection, that is what are the observation, and for that is improved, that is then we complete 6 injection. Improving, we have to in this situation also that is we have to complete 6 injection. But after giving 6 injection, if that is not improved, then in this situation we continue the injection for 4 weeks interval. But in this situation we can give that is laser, focal and grid laser, and before giving grid laser we have to do that is fundus fluorescent angiography to see the leaking point. Here that there is a leaking point and also a grid around, and we discuss a lot, and if it is the continuous process, and the DME management, and in future newer things, newer protocol will come in front, and this is the protocol. And I studied there is a different protocol, and then I prepared the T protocol, and we have to that is give injection properly and inform the patient if he cannot follow. There is this protocol, this treatment, the consequence of his this visual status, and I think that the patient will convince, and we can give a patient a good benefit regarding his vision concerns. Thank you for patience of hearing.